Gastro-oesophageal reflux affects around 20% of the UK population and can have significant impacts on physical and mental well-being. Proton pump inhibitors, or PPIs, are a powerful antacid drug and the primary treatment for reflux. Omeprazole, the first prescribed PPI, was created in the 1980s by Japanese pharmacologists, revolutionising treatment by blocking the release of acid into the stomach, helping and reducing the need for surgeries. PPIs not only target acid production, but also help prevent stomach ulcers caused by common medications like aspirin and ibuprofen. PPIs have widespread use as the most prescribed drug in the UK, with 5 to 10% of Western populations regularly taking them. Today, global annual sales are surpassing £12 billion. Despite their efficacy in managing reflux, the cumulative effects of PPIs on millions of users raise concern about potential side effects. Here is consultant surgeon and medical director of Reflux UK, Mr Nicholas Boyle, to explain in more detail.
Any condition which is worsened by the production of acid and the irritation of hydrochloric acid from the stomach, which is an extremely powerful irritant. Any condition which is associated with irritation by that acid will be potentially helped by the use of proton pump inhibitors. So because gastrointestinal conditions are so common, gastro-oesophageal reflux disease, for instance, is one of the most common conditions in the Western world, these drugs are used incredibly often. So PPIs are used to treat a whole variety of different conditions. So on the one hand, people who've got stomach ulcers, duodenal ulcers, peptic ulcers, where the lining of the stomach, the lining of the duodenum is affected by the acid produced in the stomach. By stopping the production of that acid, you can help to heal those ulcers. It's actually a misunderstanding to think that ulcers are produced by excess production of acid. That can occur, but only rarely. By far, the biggest causes for ulcers in the stomach and the duodenum are either drugs, non-steroidal anti-inflammatory drugs, NSAIDs, or Helicobacter pylori, which is a microorganism which lives in the stomach in probably a majority of the population of the world. So PPIs are used to treat people with stomach ulcers. They're used to treat people with gastro-oesophageal reflux, particularly people who've got erosive esophageal complications associated with reflux. So that's where you've got acid coming back up into the bottom of the esophagus to the extent that it burns the lining, burns the mucosa of the esophagus and causes what's called erosive esophagitis. So by reducing the acid production in the stomach, you can prevent the irritation and the ongoing irritation of that acid on the esophagus, and you can heal erosive esophagitis. So PPIs are used to treat specific gastrointestinal conditions, but they're also very often prescribed in people who are taking other drugs, for instance. So patients who are taking NSAIDs, who are taking aspirin, who are taking anticoagulants, because there is evidence that you can reduce the risk of gastrointestinal bleeding if you combine PPIs and the protection of the lining of the gut, which can potentially be irritated by these other drugs. So PPIs are used in a whole variety of different clinical scenarios. They are incredibly effective in the right people. So patients who have erosive esophagitis caused by gastro-oesophageal reflux disease, so people who've got burning of the bottom of the esophagus caused by reflux of acid, you can heal up grades 2, 3, or you can heal grade A, B, C esophagitis in the vast majority of patients by taking a course of PPIs. And patients with reflux, those who've got the classical heartburn type symptoms where patients are describing pain or discomfort or heartburn after they eat, for instance, caused by reflux, PPIs can be incredibly effective. 80–90% of patients will find that they help and will either significantly improve or abolish their symptoms. The problem is that PPIs are used very often in the wrong situation, and they continue to be used very often even when they don't work. It was a very interesting study published quite a few years ago now, which demonstrated that probably 30 to 40% of patients taking proton pump inhibitors long term don't know why they're taking them. And probably a similar number, 30% of GPs responsible for repeat prescribing of these proton pump inhibitors don't know why their patients are taking in the first place. Perhaps they went into hospital and were discharged from hospital on a course of PPIs and they just keep being given them. So very often patients are taking them for reasons which are a bit obscure. And furthermore, another group of patients are given these drugs and they take them despite the fact they don't work. So we see a lot of patients who are thought they have reflux, they're told by their GPs, for instance, they've got reflux, they're given PPIs at increasing doses and they don't work. So they take 20 milligrams of omeprazole, they go back to see their GP and say, well, we'll give you 40. Well, that doesn't work. We'll give you 40 twice a day. And it still doesn't work. And they sometimes even hide it. I tell you what, we'll add another antacid. We'll add an H2 blocker as well, because clearly, you know, there's still an acid problem, despite the fact that clearly the antacid tablets aren't working. So the problem is there are very many people who are taking these drugs inappropriately, either because they don't have conditions which will be effectively treated by the PPIs, or for reasons which are completely obscure and nobody quite knows why. So the issue with PPIs is, can they cause harm? And I think the way to always look at this is to remember that there is no such thing as a completely safe drug. Every drug has got potential side effects, has got potential problems that it can cause. Patients die from taking aspirin. Patients die from taking paracetamol at normal doses. And we know that you've always got to balance the risks and benefits of any intervention, of any drug. So the critical thing is always to work out with patients whether the drugs work, what the potential side effects can be, and whether the benefits outweigh the risks. The thing is that in recent years there's been more and more evidence published that associate PPIs with problems, and consequently many patients are increasingly worried that taking these drugs long term could be doing them harm. I think, again, one needs to balance the evidence that suggests these PPIs cause problems with the potential benefits that patients will derive from taking the drugs. So critically, when you look at all the data which has been published suggesting that PPIs cause problems, there's a whole there's an enormous number of potential complications which have been associated with drugs, with taking these PPIs. So they've been associated with the risk of bone fractures, for instance. And there are potential biochemical mechanisms by which that might be the cause, because of the PPIs might do this, because of course PPIs don't just affect the cells in the stomach, but they also affect most cells in the body. Most cells have got the same chemical pumps that you're deliberately targeting with PPIs. So there are potential mechanisms by which the bone cells, which are responsible for healing bones, get affected by these PPIs and may decrease the ability of bones to heal themselves. And that potentially may contribute to why PPIs are associated with bone fractures. PPIs have been associated with the development of gastric cancer, of stomach cancer. And there have been several studies which have suggested that perhaps there's an 80% plus increased risk of developing stomach cancer if you take PPIs. And there are potential mechanisms, again, why this might be the case, associating particularly eradication of H. pylori with the development of cancer. And then there's a whole host of other conditions, from Alzheimer's disease to cardiovascular disease to renal disease. There's a list almost as long as your arm. It's important to remember that the vast majority of these studies which have been published are epidemiological studies. So they're population-based studies where association between two factors have been looked at by epidemiologists, and most of these studies, for instance, will look to see if patients taking PPIs are more at risk of developing a particular problem, having tried to take out any other biases, any other factors of those populations which may bias the outcome one way or the other. So none of these studies prove cause and effect. They simply demonstrate associations between these two variable factors. But the way we would look at it is that ultimately there is no smoke without fire. And undoubtedly it's quite possible that PPIs can cause some of these problems. So the absolute critical next step, or next steps, are firstly more research needs to be done. We need to understand and get more data, more evidence to prove one way or the other whether or not these suggested risks are real or not. But secondly, we need to think really carefully about whether taking these pills is the right thing in every single patient. And the often knee-jerk reaction of doctors, because somebody's got a particular symptom, just to give them proton pump inhibitors and keep giving them even when they don't work, that's wrong. We must always remember that these drugs might cause problems, and therefore make sure that we only prescribe them to patients in whom we're really quite confident that the benefits outweigh the potential risks. But the thing that I think is of increasing interest, and we are going to find over the coming years of more and more importance as we understand more fully, is the consequence of our gut biome and the billions and billions of bugs which live in our gut and the influence on our health. And what we do know, of course, is that we have gastric acid. We produce acid in our stomach for a good reason. You know, it's not normal to turn off the production of acid in our stomach. And the reason that we have stomach acid is effectively, there are lots of reasons, but the two primary reasons are, one, to help with the digestion of our food, to help break up food, and to help in its absorption and its digestion. But secondly, because the stomach acid is a first line of defense against all the bugs that we inevitably swallow when we eat, every time we swallow. So normally the high levels of acid in our stomach will kill the vast majority of bacteria. And if you stop that acid production in the stomach, you remove that barrier. That first line of defense against all the bugs that we inevitably swallow is taken away. Of the risks that we know are associated with PPIs, one which is real, which is demonstrated, and there's no doubt about, is there is an increased risk of enteric infections, an increased risk of getting stomach bugs and getting gastrointestinal infections if you take PPIs. And almost certainly that's because we're removing that barrier. So studies have been done which have shown quite clearly that if you take PPIs just for a few weeks, you will change the normal balance of bacteria in our gut. People have looked at the variety of bugs that you can assess in the feces, and if you take PPIs just for 6 weeks, these will change. So we know that PPIs affect your gut biome, and we know your gut biome can affect health in so many different ways. Almost certainly bugs in our gut will modulate the way that the body uses insulin. And if we change the gut microbiota, that probably may well be a mechanism for how diabetes seems to be associated with patients who take PPIs compared with those who don't. Similarly, we in Reflux UK have demonstrated that in patients who have small intestinal bacterial overgrowth, who have developed an abnormal number of bacteria in the small bowel, which are usually relatively sterile, whilst the colon, The large bowel is the home to trillions of bacteria, and we rely upon those for our health. The small bowel, the bit of gut between the stomach and the colon, is relatively sterile. There are a few bugs in that, certainly in the first bit of it, just after the stomach, because they've been killed by the stomach acid. But in small intestinal bacterial overgrowth, the small bowel is colonized by bacteria, which usually shouldn't be there. And we've demonstrated that in patients who test positive for SIBO with breath tests are more likely to respond to treatment of that in terms of reflux symptoms than those who don't. So in other words, we very often will see patients who come to us and they've got reflux type symptoms. They've developed heartburn, but very often laryngopharyngeal LPR type symptoms as well. Very often they've been put on PPIs by their GPs because the GPs think, well, this must be reflux, and giving them PPIs will help it. And sometimes it can make it worse. Sometimes the PPIs can actually make the reflux symptoms worse. And so what we now do very almost routinely in patients who don't respond to PPIs, who have got reflux symptoms, we'll test them for SIBO, we'll do breath tests, and if they are positive, then we will treat them, we'll treat the SIBO, and we will find that actually a majority of them will find a benefit, their reflux will improve. So very often we'll see patients who've had reflux for a long time, have been taking PPIs for a long time, and then they'll develop small intestinal bacterial overgrowth and these other problems. So it can be very difficult to treat the SIBO-related symptoms whilst patients remain on PPIs. Sometimes a diet can help to reduce those symptoms, but actually eliminating SIBO whilst patients remain on on PPIs can be very challenging. So actually it's a strategy which we will often use, is patients will choose to have surgery. That will then enable them to get off their PPIs. They're then more likely to be able to re-establish a normal gut biome by modifying their diet, by eating a healthy diet, a highly diverse diet, lots of different fruits, nuts, grains, etc. And that will help to re-establish a normal gut biome. But if it doesn't work, then treatment with antibiotics is more likely to be effective. So that's a strategy which we will often use with patients. One of the complications, one of the side effects of anti-reflux surgery has been known to be what's called gas bloat. So we know that after anti-reflux operations, patients are quite likely to experience significant bloating, significant flatulence, because they can't belch so easily very often. And we've actually published a study which has demonstrated that small intestinal bacterial overgrowth and another condition with an abnormal prevalence of bugs in the gut, intestinal methogenic overgrowth, is another so-called dysbiosis. We've demonstrated that in patients who come to see us, who've been taking PPIs for many years, these conditions, SIBO and IMO, are more common. So it's quite likely that the reason patients get all the bloating associated, which are thought to be secondary to the surgery, actually isn't caused by the surgery at all, but it's produced by the gas being produced in their gut by all these bugs, which in turn has been caused by taking PPIs over many years. So another strategy that we will often do is we will have a very low threshold to test any patient undergoing and who's like to undergo anti-reflux surgery, test them to see if they've got SIBO, test them to see if they've got IMO, and if they still have bloating and belching after their surgery, we will treat that, and we'll be more likely to help those symptoms rather than just put it down to, well, it's the fact that you can't belch so well, you've got to live with them. So the side effects associated, the potential complications associated with PPIs are of varying kinds, and the evidence supporting the risks also varies. So we know, for instance, it's undoubtedly the case that patients taking PPIs are more likely to develop gastrointestinal infections. Hypomagnesemia, a low magnesium in the blood, is a definitely well-recognised side effect which can affect a small number of patients who take PPIs. So there are some conditions where it's absolutely clear of what the potential risks are.